Good morning, everyone, and welcome to the WPS Government Health Administrators Evaluation and Management Risk Question and Answer webinar. My name is Ellen Barra, and I'm a member of our Provider Outreach and Education Department. On the call with me today is my friend and colleague, Rachel Wood, who is also with Provider Outreach and Education. She is one of our nurse analysts. In addition, we have a member of our medical review department on board to listen to the type of questions that we're getting today. The first slide that we have is our disclaimer, and this is something we use with all of our presentations. If you've been with Medicare for any length of time at all, you know that Medicare rules do change, and they change often. This education is a tool to assist you in submitting your claims correctly. The CMS website contains the relevant laws, regulations, and rulings, and those are the final determinants of coverage along with your documentation for your evaluation and management service. We will provide responses to your question based on how you have asked the question. But Medicare rules, again, determine that final coverage. CMS does prohibit recording of the presentation for profit-making purposes. So if you are recording, if you are doing screenshots, we would ask that you stop. Again, we are recording this presentation. It will be available probably within the next week, both on the WPS website. You would go into the training into the training center, and then scroll down to Encore presentations, and then you can find this presentation. This will also be available on our YouTube channel as an Encore presentation, both in the Encore playlist and then also in the Evaluation and Management playlist. In that YouTube playlist under Evaluation and Management, we do have recordings of the previous webinars that we have done. We went through choosing your level of service, and then we divided the E&M services up into categories, such as office or other outpatient, inpatient, etc. And we did 2 webinars for each of those categories, one going over the rules concerning that category of service, and then a second one with a documentation review, where we went through the documentation, looked at either time or the medical decision making, the problem, the data, and the risk, and then came up with a procedure code that we felt like was supported by that documentation. I encourage you to take a look at that information. We did receive some pre-submitted questions, and we'll kind of put those into the presentation as we go. We are going to be talking about the levels of risk and the examples for the levels of risk as given by the American Medical Association. These are examples only, and you'll see that as we go through the information. We did receive questions on topics other than risk, and these will not be part of our presentation today. We did have some questions on the add-on complexity code, the G2211, and we also had questions on the social determinants of health assessment. We are going to hold webinars on these items in April, and they have been advertised. So if you've not signed up for those and you're interested in that, that registration is available on our website under the live event. One of the pre-submitted questions that we had was whether or not Medicare would apply an assumed risk to the documentation. And the answer to that is no, we won't make assumptions. When we or the comprehensive error rate testing contractor, the special medical review contractor, OIG, whoever is looking at documentation, we're going to base the decisions on what is in the documentation. As you're aware, if it wasn't documented, then it wasn't done. Another pre-submitted question had to do with talking about or using the term risk as it applies to the problem and as it applies to the risk management or the risk to the medical decision making that you're actually making for that patient. And those are different. The complexity of your problem, or the patient's problem rather, goes into the decision on which level of problem that you're going to choose that may or may not carry on into the risk of the management of that patient. You could have a situation where the problem is very complex, or you believe that the problem is going to be very complex, but when you get into the risk section, the risk to that patient from the management decisions that you're making may not necessarily compare to that. And then another pre-submitted question is, what if the practitioner documents the risk level and you as the coder or biller do not agree? Well, you want to go back to that practitioner. If a physician or a non-physician practitioner documents the level of risk and they indicate in their documentation the risk level is low, that's what Medicare will assign for that. So if you disagree with your providers, then you want to go back to them to determine why they have chosen that level. And then just as a reminder to you, evaluation and management and reviewing that documentation can be subjective. So if you do not agree with a response that you have gotten from a Medicare contractor, and you believe that documentation does support the level of service that you have submitted, you have the right to appeal. Take advantage of that. When you're submitting that documentation back into us, though, in your appeal request, don't simply say, see the documentation, because we've already seen it and we've already made our determination. What you want to do is you want to be specific. Point us to the information within that piece of documentation, within that medical record, that you believe really supports the level of service that you have submitted into Medicare. So we've got some information here at the beginning just to kind of remind you. Evaluation and management services must be medically necessary. That's part of the law that goes along with the Medicare program itself. So what the documentation will have to show is that evaluation and management service is reasonable and necessary to diagnose or treat the illness or injury, or to improve the functioning of a malformed body member. So that's one of the first pieces of information that Medicare contractors would be looking for, is what is that medical necessity? The American Medical Association has made fairly drastic changes to the description of procedure codes and to the instructions they have provided on choosing a level of service. January 2021 encompassed the office or other outpatient services. January 2023 included the other categories of service. So you can choose your level of service based on either time or medical decision making. Two exceptions to that: emergency department would not use time, it would only use medical decision making, and critical care only uses time. So see, the American Medical Association divided this up into categories or elements of the service: the number and complexity of problems addressed at the encounter, amount and complexity of data that was reviewed or analyzed, and then the risk of complications and or morbidity or mortality of the patient management. And the language and the instruction on that is really what is key. It is what is the risk to that patient from the medical decisions that are being made by your practitioners. The next slide just has information for you on the level of service. The one thing I want to draw your attention to is that for any given level of service, you must meet or exceed 2 of the 3 levels: problem, data, or risk. If you meet or exceed 2 of those, the fact that your third one may be lower, that's not a problem for you. You can still do the other 2 levels. What I have up on the screen for you right now is the AMA definition of risk. You can see their probability or consequences of an event. This is contained in both the AMA coding changes document that's available on their website, and the same definition is available within your CPT book. So it's the consequences of an event. The assessment of the level of risk is affected by the nature of the event under consideration. So the level of risk is based on the consequences of the problems addressed when appropriately treated. Risk also includes medical decision-making related to the need to initiate or forego further testing, treatment, and/or hospitalization. The risk of patient management criteria applies to the patient management decisions made by that reporting physician or other qualified healthcare professional as part of that reported encounter. So let's talk about what this means when we're looking at our patients, when we're looking at the documentation concerning what has been accomplished and what has been provided to that patient during that encounter. So you have a patient, for an example, with a stable chronic condition, and you renew those patients' prescriptions. Well, what is the actual risk to the patient from this encounter? If the patient has been on these medications for a time, is there really a higher level of risk based on the fact that they've been on these medications and there hasn't been any problems so far? So again, it's not necessarily what decisions the physician or practitioner has made, but it's the risk to that patient from those decisions that have been made. It all goes back to proof of thought. What is the probability or consequences anticipated for this patient from that medical decision making that was performed? Another pre-submitted question we had was, would requesting a patient to go to the ER, would that be the same as a decision regarding hospitalization? And the answer to that is no, because who's making the determination the patient has to be hospitalized? Is the physician making that determination, or is the ER physician going to make that determination? So the risk table, and we have the title of that table here, risk of complications and/or morbidity or mortality of patient management. Again, this goes back to proof of thought. In determining the management of the patient and determining the risk of that, that's going to be specific patient possible complications, morbidity, or mortality to that individual patient. The items listed within the risk element of the medical decision making are examples only. They're not absolutes. We will provide some scenarios as we go through this information for you. And one of the big ones is that ordering a prescription drug does not always mean that you have a moderate risk for that patient. So what we have up on the screen for you now is the information from the risk category or the risk element for both straightforward and low. So straightforward and low is where the practitioner has identified minimal or low risk to the patient from the treatment plan chosen for this patient. This could also be situations where your practitioner is not identifying any risk to the patient. Again, I want to remind you that the examples as listed in the AMA document and in CPT are just that. They are examples, they're not absolute. You want to help educate your practitioners to identify what they believe is the level of risk to that patient. This identifies their thought processes and what they think is happening or could happen with that patient. We had a pre-submitted question on how would we categorize continuing use of a CPAP for a patient. This question would probably fall into the straightforward or low. Again, the doctor could identify situations such as the patient has been using the CPAP for quite some time. So again, what would be the risk to that patient from that, from continued use of that? Maybe this is something that the patient is just starting. And again, that could mean a different level of risk. Your physicians and practitioners really need to identify that. We have up on the screen for you the definition of morbidity. Mortality, of course, is pretty easy to understand. This is whether the practitioner believes the patient could die from the problem addressed and the treatment plan chosen for that patient. Morbidity, however, is where the patient could suffer long-lasting issues from the problem and the treatment plan that's chosen for that patient. The next one that we have then is moderate risk. And the first thing I want to say here is prescription drug management is listed here, and this is the one that we get the most questions on. You can't compare the way that you use the term prescription drug management under the 1995 and 1997 documentation guidelines because the instructions from the AMA are now different. Again, beginning in 2021 for office or other outpatient, in 2023 for the other categories of service. So the fact that your physician has renewed a prescription drug does not in and of itself equate to a moderate risk. And I realize that that's a difficult concept. But you have to remember that the AMA has changed the instructions for the use of medical decision making. Under the 95 and 97 documentation guidelines, if your physician identified that they were continuing meds, they didn't make any changes, that kind of stuff, you could count that. For the new guidelines, you cannot. It is all based on the risk to that patient. And we'll talk about prescription drug management on the next slide. So decision regarding a minor surgery. Well, whether the surgery is major or minor is for that specific patient. This is not based on the global period that 0, 10, or 90 days that Medicare assigns to a surgical procedure. The practitioner themselves would need to make that determination. For an example, the removal of a gallbladder. For an otherwise healthy patient, the laparoscopic removal is pretty straightforward and not a big risk for that patient. However, if you have a patient that has other health issues, including possible breathing issues or heart issues, this same procedure could place that patient at higher risk. Again, it goes back to the specific patient and what your physician or practitioner is identifying as the risk to that patient. All procedure codes or all surgical procedures have an inherent risk, from an injection into the knee to open heart surgery. There are risk factors, bleeding, infection, just to name two of them. What you want to be looking for in that practitioner's documentation is the level of risk that's applicable to, to that individual patient. The next one there, a decision regarding an elective major surgery. What we're looking for here really has to do with timing. But that the documentation itself is not identifying patient or procedure risks. So we're talking an elective surgery, meaning that it's not going to happen today, it's probably not going to happen tomorrow, but it is being planned for that patient. That's part of the medical decision making that is being made. Evidence-based calculators can be used for this, but they are not required for Medicare. And then the last one there, social determinants of health. This is where the patient's diagnosis or treatment is significantly limited. So what you would want to document there is what is the social determinants of health, what is the issue, and how is that affecting the patient's treatment. We had a question, a pre-submitted question on whether you can count a modifier risk when the SDOH affects the MDM and also bill for the standalone SDOH assessment. And the answer to that is yes. This is two different pieces of work that you're doing. You're identifying the risk to that patient, and if you're using the SDOH assessment, that's another piece of work that you're doing. We will have more information on the SDOH assessment that we will be covering in a future webinar. We had a pre-submitted question concerning ordering a stress test for the patient. Well, the answer goes back to what is the risk to this patient from that decision that has been made. Do you have an otherwise healthy patient that you want to have a stress test done on? And how risky is that test going to be for that patient? For some of your patients, ordering a stress test, risk is not going to be that high. For other patients, whether you do a physical stress test or you do a chemical stress test, that's going to be very risky for your patient. But your practitioners need to identify. And then another pre-submitted question was a decision regarding surgery. Does it make a difference if you do the surgery on the same day? Does it make it a higher or lower risk? And the answer to that is no. You would just need to evaluate that evaluation. You would need to evaluate the E&M for the risk and the modifier usage, obviously. We just completed a modifier Monday using or discussing modifier 25. This is available on our Encore channel, Encore webpage, and then also on our YouTube channel. So now let's talk about prescription drug management. This is prescription medications. And again, I want to remind you that it is an example only. It's not an absolute. So, you know, if the physician has mentioned prescription medications at all, it doesn't necessarily mean that you can always assign it a moderate level of risk. Again, I think this is one that we're receiving the most questions on, we're receiving the most pushback on. It won't apply to every patient for which a practitioner ordered or evaluated prescription drugs. For an example, you order an antibiotic for a patient with an upper respiratory infection. What is the risk to that patient from taking this medication? Have they taken it before? Another example, the practitioner is seeing an established patient and renewing their medications. What is the risk to this patient from renewing those medications? If your documentation cannot support a moderate risk without, using the words prescription drug, then the service probably is not going to qualify for that moderate level of risk. Remember the definition of risk, the probability or consequences of an event. What are the expected or possible consequences to that patient of renewing the patient's ongoing medications? What is the expected or possible consequences of ordering a new medication, changing a dosage, or discontinuing a medication? This does not include prescription drug management. That example does not include a drug that you're going to administer to the patient through an injection at the time of the service. That's going to be your procedure, either an injection, IM, an IV type of an injection into the joint, etc. Prescription drug management also is not generally over-the-counter medications, but again could be, depending on the risk to that patient from the over-the-counter medications and any possible interactions with other medications that patient is taking. Documentation, of course, would have to support, and it all goes back to that risk. What is the risk to the patient from the medical decisions that are being made? And again, you can't equate what were the instructions under the 95 and 97 documentation guidelines to now the 2021-23 AMA medical decision-making guidelines. A pre-submitted question that we had is, what about starting a medication in a hospital setting and then continuing to watch that medication for efficacy during the stay? Again, it goes back to the risk. When you're starting that medication, there could be a higher level of risk. When you get into the subsequent days, how are you identifying, how is the documentation identifying the risk to that patient from that med? Social determinants of health. These are things, economic and social conditions that can affect the health of people and communities. We give you some examples there: food or housing insecurity, just as an example. So let's talk about that. When you order insulin, for an example, for the patient, but they don't have electricity, so how are they going to keep that insulin at the right temperature? So the social determinants of health and the information that's been provided to your physicians and practitioners will affect the medical decision making that your practitioner is doing. In the example with the insulin, the doctor then, because they're aware the house does not have electricity, they're aware then that they have to make a different medical decision. The insulin itself is not going to work because that has to be refrigerated. Another example going along with, we'll stay with diabetes, nutrition information. You're providing great information to the patient about what they should eat, what they should not eat, etc. But they can't get to the grocery store that has the fruits and vegetables. Maybe they don't have transportation there, so they're really doing their shopping at a local convenience store. Well, that's going to make a difference in how your physician or practitioner is going to be treating that patient. So this is accounting for the additional work your practitioner has in figuring out those changes to the treatment plan or the community resources that can assist. Another example, you order a medication for the patient, but they tell you that they can't pay for it. Well, what does that practitioner do now? If they have that information, they're going to make a change in their medical decision making. They're not going to stop with, well, that's too bad, but this is the medication, I want you to be on. You have to figure that out. Your doctors are not going to do that. They're going to work with that patient in order to determine what is the best medical decision making I can do for your particular situation. The next thing that we have is high risk, and there are several different categories here. Drug therapy requiring intensive monitoring, we're going to talk about on the next slide. Decision for an elective major surgery. Again, this goes back to timing of that major surgery with identified risks. Now, again, we're not talking about, generalized risk, bleeding, infection. When we're talking major surgery, we're in the liver, we may nick the hepatic artery or something like that. But it's risks to that patient from the particular medical decision making that's done. Emergency emergency major surgery. You're determining that the patient needs this surgery right now. Decision for hospitalization or an escalation of hospital care. Is your practitioner the one making the decision for the patient to be hospitalized? Or are they sending that patient to the ER for the ER physician to make that determination? You want to look at your documentation on that and see exactly what your physician or practitioner is determining. If your practitioner is deciding that the patient needs a hospital level of care, why are you sending them to the ER first? This really just increases the cost to the patient and to the Medicare program. If your practitioner does not have admitting privileges, and that's fairly common, then you want to work with that hospitalist or the specialist you believe that the patient needs. An escalation of care is going to be changing from like a hospital level of care to a critical care situation. The DNR or de-escalation because of poor diagnosis, you want to document that. Why is that the decision that you're making? And based on that and that shared decision making with that patient, what is your anticipation of the risk to that patient? The last one, their decision regarding parental controlled substances. We've received a question on what is a parental controlled substance. These are the scheduled drugs as identified by the DEA. I believe that I placed that in the link to the DEA website in the information I placed for Rachel to place into the chat. Rachel, when we get to the questions, if I didn't give that information, let me know, and then we will send that out to you in an email. Oh, no, wait a minute. I'm sorry. The link is also on your resource slide. Sorry about that. So when we're talking about decisions regarding those parental controlled substances, those are going to be part of that identified scheduled drugs as identified by the DEA. A question that we have received often is how do we count or how do we evaluate a referral to a specialist? Well, the question goes back to what is the risk to that patient from the decision your practitioner is making to refer them to a cardiologist? Is that a high risk to the patient for that referral? Is it not a high risk to the patient for that referral, etc.? Another pre-submitted question is, would a decision for the parental controlled substances, PRN, or as needed apply? And the answer to that is yes. Again, documentation would need to support that decision. Another pre-submitted question we received was, how would you assess risk when determining the possible LOS or length of stay? The LOS by itself would not determine the risk. The patient does need a hospital level of care, but your documentation would need to show why and what is the risk to that patient from that medical decision making. Another pre-submitted question was, the patient was sent to the ER in need of a higher level of care with stat imaging evaluations and labs for possible bowel obstruction. Well, again, we go back to what is the risk to that patient from that medical decision making. And again, your documentation needs to show, are you identifying that you want the ER now to take over that, the care of that patient, and they're now going to make the decisions? Or again, are you wanting that patient to be admitted? And if so, why send them to the ER first? Another pre-submitted question that we had is, can you use the decision for hospitalization as high risk for a subsequent hospital visit? And the answer to that is no. They're already in an inpatient setting and you do not have an escalation of care. Another pre-submitted question is, can both the ER physician and the hospitalist use a decision for hospital care, or is that really double dipping? Well, again, we go back to who made that decision. Did the ER doctor make that decision and now they're transferring that patient to the hospitalist? Where the hospitalist really wouldn't be making that decision at that point, right? The ER doctor made that. So it all goes back to your documentation. Who's making that decision? So now let's talk about the drug therapy monitoring for toxicity. As you can see here, the drug has the potential to cause serious morbidity or death. An example could be chemotherapy drugs, although this is not exclusive. Other drugs can fall into this category too. When you're doing this monitoring, you're doing testing on the patient to determine any adverse effects. You are not performing the monitoring to determine the efficacy of the drug. An example of this could be the INR testing for patients who are on warfarin therapy. Are you monitoring for the possible morbidity or death, or whether that drug is really working the way it should? Short term, this could be daily monitoring for the adverse effects. For a long-term drug, you are monitoring and doing this testing at least quarterly. And as you can see up on your slide, history or exam does not qualify as that monitoring. It does have to be testing for that patient. So the next thing that we have then here for you are the resources. And we did provide the link for those controlled substances. So you can go and take a look at what drugs are considered those. We included the CMS Internet Only Manual section, and then also the CMS Guide for Evaluation and Management Services. So now we want to go ahead and open it up for questions. So Rachel will be taking a look at those questions in our chat.
All right, let me just get to the top here of our questions. All right, so our first question is, can you clarify the decision regarding hospitalization from column 3, risk of complication and or morbidity or mortality of patient management of the MDM table is assigned when the patient is seen in the emergency department? The patient is seen by an emergency physician who makes the determination that the patient should be admitted to the hospital. Since the ED physician does not have admitting privileges, he asks a hospitalist to admit the patient to the hospital. The hospitalist evaluates the patient and decides that person should be admitted. When both the ED and hospitalist convey a decision to admit, who gets the credit?
Okay, the person who actually decided the patient needed to be admitted. I saw the chats kind of pop up a little bit where I can see them just real briefly. And we want to go back to who's making that decision. And the other thing we want to go back to is the cost. If we have a patient in the office and the doctor says, oh, I think you need to be admitted, so I'm going to send you to the ER, and then the ER doctor looks at the patient and says, oh, I think you need to be admitted, I'm going to transfer you to the hospitalist, and now the hospitalist has said, I think you need to be admitted, how much additional cost has just been added to that patient from that ER visit, both the professional side and the facility side, to the patient and to the Medicare Trust Fund, when the doctor in the office already knew that the patient needed to be admitted. We understand that there are some hospitals that don't do direct admits, that type of thing, but the decision and how you count that is who made the decision that the patient needed to be hospitalized. That's the person who can actually count that. In the situation I just described, the physician is really referring the patient to the ER physician. The ER physician is referring that patient to the hospitalist to make that final determination as to whether the patient needs to be hospitalized. Next question.
All right. If a patient is seen in a clinic setting and then transferred to the ER, is that considered high risk?
It depends on what's going on with that patient and your physician's documentation of the risk to that patient from the medical decision making to transfer that patient. I can't respond to that question the way that it has been asked. We don't have enough information to determine the level of risk to that patient from that decision. Next question.
Can a provider document the risk? For example, patient is moderate risk for complication or morbidity.
Sure, and we want them to document that. That will make your job as the coders and the billers and the auditors, a whole lot easier, because your physician is the one who has to make that determination, physician or practitioner, as to the level of risk for that patient. Next question.
All right. If a provider documents that they are monitoring and managing a patient's ventilator multiple times per week to avoid respiratory failure complications, does this support moderate or high risk? In this example, the provider is not billing for vent management.
In the example that you have provided, the doctor needs to assess that level of risk. So if they're monitoring that patient multiple times per week, in order to determine the situation with that patient, whether things are working the way that they're supposed to, etc., that possibly could fall into the high level of risk. Probably not on a continuous basis. And of course, documentation would have to support the frequency of that monitoring. But what it really boils down to is, what is your physician assessing as that level of risk? So the patient had an encounter today, they're going home on a ventilator, they've been on a ventilator more than likely, and we're monitoring that. So what do I determine is the risk to my patient from being on this ventilator, whether it's short-term or long-term? Next question.
If the physician orders 3 or 4 medications in the ER, all given IM, sub-Q, or IV, can this be moved to high risk because based on the number of drugs given?
Okay, the number of drugs and the drugs given really don't make the determination. It is the risk to that patient from that medical decision. So if the ER physician is ordering multiple drugs or ordering one drug for that matter, how are they assessing the risk to that patient of morbidity or mortality from the decision that was made? So if you're giving a drug that unless you, really pay attention to the drug, it could kill the patient within 5 minutes, obviously that's going to be a much higher risk, and therefore you can assign it that way. If you're ordering a drug such as an IV antibiotic, as an example, what is the risk to that patient? That's a fairly standard drug. Most patients, they don't have a risk of morbidity or mortality from the ordering of that drug. Next question.
What stating a procedure is taking place today, noting emergent or urgent, support emergency major surgery?
You could certainly count that as a higher level of risk to that patient because they need that surgery today. And again, you want to keep in mind that what's listed in that category, in that chart under risk, are examples. So, you could be doing a minor procedure on the patient today in the office, but because of the patient's health conditions, that minor surgery really is a very risky for that patient. So you can use that information there as examples, not as absolutes though. But in the question that was asked, a surgery that the physician or practitioner feels like needs to be done today could lead to a higher level of risk category. Next question.
With regard to medication management, if hypertension is stable and has been with no problems with the current medication and the medication is refilled, if the patient stops the medication, there is a risk. So would that be a factor providers could consider?
Well, your physician is going to document that. Do they believe that the patient is non-compliant with medications? That could lead to a higher level of risk. But if your physician has not documented that, or they have no information or documentation that they believe the patient will stop their medication, then more than likely you have a straightforward or low level of risk in the situation that you have described. Next question.
What if the provider has a smart phrase in their documentation that is used for every patient for risk? Can we use that for every patient?
If it's the same sentence or something like that, I can tell you that Medicare will catch on to that and Medicare will take money back. Using macros and things like that within your documentation, there's nothing wrong with that. That can help reduce your physician burden. It can, get information into the chart. However, it needs to be specific to that patient. So if Medicare sees a trend, if we're looking at documentation and every patient that comes in is identified at a high risk, we're going to be questioning that. Next question.
The American College of Emergency Physicians clearly states that a CT with contrast is always high risk due to the risk of reaction to the contrast and long-term radiation exposure. Does WPS have any thoughts on this?
WPS says that when we're talking about evaluation and management services, documentation has to support that level of risk. So if the physician has documented that the patient is, getting ready to receive an MRI with and without contrast, or just with contrast for that matter, they need to identify the risk to that patient from receiving that treatment. So for an example, if you have a patient who has received the same contrast material before, and that physician is aware of that, and the patient did not have any problems previously, then you're going to have a lower level of risk. If this is the first time that that patient is receiving that contrast material, then you could assign a higher level of risk to that patient. It has to be specific to the situation and to the individual patient that is being treated. I understand the College of Emergency Physicians has a lot of really great information out there, and that's fantastic. However, Medicare rules apply to Medicare patients. Next question.
All right. Regarding prescription drug management, coders and auditors are not clinicians. How do we determine the risk of medications?
You go back to the physician. If the physician has not documented their thought process on that level of risk from the decision that they're making, and it's not obvious to you with your expertise as coders and billers and auditors, then you need to go back to that physician and have them identify the level of risk from the decision your practitioners are making. Next question.
All right. So does sending a patient to the ER not count for a high level of risk?
Not necessarily. It's why you're sending them and what it is. Let's back up a second. Okay. So we have a patient that comes into the office and we believe that the patient needs to go to the ER. Okay, what is the risk to that patient from our medical decision making, from the medical decision making that your physician or practitioner is making? So if they believe that the risk, when you're looking at the problems, when you're looking at this at the medical plan for that patient, is placing that patient at a higher level of risk, then you can count it that way. In the situation described, more than likely, a patient that needs to have an ER level of care as opposed to a hospital level of care could be a higher level of risk, but it's all going to go back to that documentation. And the decision making that your physician or practitioner is making. Let me give you an example. Patient comes into the office and they're having a regular encounter and the patient starts experiencing signs or symptoms of a stroke. Okay, that's a big medical decision to send that patient to the ER, whether you're calling an ambulance or you're sending them directly. That's a big risk in that medical decision making that you have made. If, on the other hand, the patient comes in, they're maybe they're dehydrated, we'll give that as an example, and the doctor says, okay, really, I'm going to send you to the ER so they can do some IV hydration for you. You can go over there sometime later today. That's not going to be high risk. That's probably not going to be moderate risk for that matter. But it all goes back to your documentation and what it is that's going on with that patient and the decisions that your physician or practitioner are making. Next question.
Does risk of not following the treatment plan make a difference in the level of risk?
It could. if your physician or practitioner has reason to believe that that patient is not going to follow the plan. Because if your physician or practitioner believes they're not going to follow the plan, the physician or practitioner is going to do and be looking at additional things they can do, either to ensure patient compliance or to adjust that plan to something that the patient will comply with. Next question.
This next one, I think we might need some more information. What's entered is, what about monitoring for infectious disease type reactions and its effects on patients with end-stage renal disease?
Well, the same situation will apply. In what you have described, the patient has an infection such that they have called in an infectious disease specialist. So that tells me that the infection is a pretty big one, for lack of a better term. In addition to that, the patient has ESRD, which means that there's a lot of different health problems that are going on there too. So what you'll be looking at, looking for and looking at in the documentation is what is the risk to that patient and how is your physician identifying that infectious disease specialist identifying that from the infection that's going on, the considerations that that physician or practitioner is having to make encompassing that ESRD and any additional diagnoses or problems that the patient may have. In that situation, you could have a high level of risk. In most situations and examples that you guys are providing to us, it could go all the way from straightforward to high. It depends on the documentation that is provided within that medical record. Next question, and I think this will be our last one, Rachel.
All right. If a consulting doctor makes recommendations about a medication, but the attending actually orders it, who would get credit?
Okay, who's making the decision for that prescription medication? And what is the risk to the patient from that prescription medication? In a consulting situation, if it's an actual consult, that consulting physician is providing advice, opinion, etc., back to the requesting physician. So more than likely, they're going to be the ones that have ordered that, but they need to document what's the risk to the patient from this decision that I'm making, whether it's I'm deciding to do a prescription, I'm deciding not to do a prescription. That could go to a moderate or high level, either one. Based on shared medical decision making with that patient, we decide that the side effects are not worth the benefits that we're going to get from this medication. It all goes back to proof of thought. What is your physician looking at? What are they deciding for that patient? And how are they deciding how risky that is for the patient's morbidity or mortality? So we'll go ahead and stop there with the questions. On behalf of Rachel and myself, we want to thank you very much for your attendance today. We're aware of the struggles that you and the provider community are having in understanding these new guidelines, in making the switch from the 1995 and 1997 guidelines to these new guidelines. We're struggling along with you, trying to make sure that we're providing you with the best information that we can. So again, thank you for your attendance. We do encourage you to take that survey. We want to hear your feedback. So on behalf of Rachel and myself, this will then conclude the presentation. You can now disconnect. Thank you everyone for joining.